Good afternoon. My name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement for the MAVEN Project. And thank you all for joining us today, and our friends at Cherokee Health Systems in Tennessee for requesting today's session. We're here to learn about abnormal tests in pediatric endocrine practice, when to worry and when to reassure with Dr. Paul Kaplowitz. Dr. Kaplowitz is a professor emeritus of pediatrics at George Washington University School of Medicine and the Health Sciences and in the Division of Endocrinology at Children's National Hospital in Washington, D.C. Dr. Kaplowitz was on the faculty of the VCU School of Medicine in Richmond, Virginia, and then moved to Washington to become Chief of Endocrinology at Children's Hospital. Since retiring from Children's, he has been volunteering at Neighborhood Health VA, a federally qualified community health center in Alexandria, Virginia. Dr. Kaplowitz, it's great to have you here today, and I'll turn it over to you.
Thank you. I'm glad we have such a good crowd of about 35 people. And what I wanted to tell you is that in the course of this talk, I will be presenting about 7 cases that I would like for you to react to. So if you could, we are going to try it this way. If you could put your, each case will have a number and will have several options for what you would do in that situation. If you could put the number of the case and the letter or number of the option, then I can review that and give you some feedback. So we'll start with disclosure that none of the individuals in a position to influence this content have relevant financial relationships to disclose. And as Jill said, this is accredited by the ACCME and for 1 hour of credit. So I just wanted to summarize what I hope that we will accomplish today. And we're going to discuss several cases involving somewhat abnormal endocrine studies to illustrate how an endocrinologist, such as myself, would interpret and act on the results. But we'll also discuss a more general issue of trying to define when a test is truly abnormal and how it relates or doesn't relate to the problem which led to ordering the test in the first place. And this is to encourage thinking about doing less endocrine testing in those situations where a helpful abnormal test is unlikely. So here is the first case. A 13-year-old girl is brought in because of severe fatigue for the last 3 months. She has trouble getting up in the morning, even after sleeping 8 to 10 hours. Her appetite has not been affected. Her medical history is negative. She's not on any medications. Your physical exam is normal, and you order a bunch of tests, which are normal except for thyroid, where the free T4 is normal, but the TSH is mildly elevated. So the question is, what would you do next? 1, repeat the tests. 2, consult a pediatric endocrinologist. 3, start thyroid hormone and then try to get her seen by an endocrinologist as soon as possible. Or 4, tell the parents that none of the tests ordered suggests a particular reason for their daughter's fatigue. So I'm going to give you about 30 seconds to enter into the chat, for case 1, which of those options you like the most, and I will check them and give you some feedback. Okay. So it looks like most of the people who've logged on have selected option 1. And 1 person selected option 4. So let me close the chat and go to the next slide. Okay, so we're going to discuss 2 cases, and then we'll, so basically, just going back, repeating the thyroid tests is usually not very helpful, because particularly if it's, a short time away from when you did your initial tests, they're not likely to change very much. So you're not going to get much new information. But the important thing is that with the free T4 being normal and the TSH being just borderline elevated, the important message to convey to the parents is that none of the tests ordered suggest a particular reason for her fatigue. So this is one of those situations where people frequently consult with endocrinology or occasionally start thyroid hormone, but I think the important thing is not to be too thrown by, the borderline abnormal test. But now we have a slightly different scenario. We've got a 10-year-old obese boy. He's 40 pounds above his ideal weight. And as many people do, thyroid tests have been ordered to exclude hypothyroidism as causing the weight gain. This time the TSH is fine, but the free T4 is a little bit low. So you have four options. You could refer to endocrinology because you suspect primary hypothyroidism with a delayed TSH rise. You could also say, well, if the free T4 is low, but the TSH is normal, maybe this is a pituitary problem, needs to see endocrine. Or you could view the results as a benign normal variant and try to reassure the parents that the thyroid is not the issue. Or you can repeat the tests, and if the results are the same, then you could refer. So why don't you, I'm going to give you 30 seconds to enter your comments in the chat. I'm trying to find the chat bar. Oh, there it is. Okay, so in this case, we see a lot of people. We have more variety here. We have a lot of people choosing B, C, and D. Yeah, so a lot of people just are undecided. So we have some people saying the results are benign, and some people saying repeat the tests, and if the results are the same, refer. So let's talk a little about thyroid physiology. When everything is working properly, an illness of the thyroid, which would result in a low T4 and or T3, will result in a loss of negative feedback and therefore a significant rise in TSH in order to restore the thyroid levels to normal, as you can see in this limb. And then that will shut down, theoretically, TSH. So the idea is that a failing thyroid gland, the TSH will rise, but the thyroid will not respond. And thyroid has many, there's T4, which can be converted peripherally to T3, or T3 can come from the thyroid, and it has effects on the heart, the liver, the bone, and the central nervous system. So the question really with these two cases are to ask yourself if the out of range results are meaningful in the context of the patient's symptoms. So generally, patients with true primary hypothyroidism, even mild cases, will typically have a TSH not in the, a little above 5 range, but greater than 10. And if the TSH is greater than 20, that's a little more urgent, and those patients really should be referred promptly. But the symptoms are very variable, and they really depend on the duration of the hypothyroidism and how low the free T4 is. So if the free T4 is normal, there are really not going to be any symptoms. And definitely obesity of the 40-pound weight gain variety is not going to be due to mild hypothyroidism, and even severe hypothyroidism will only cause minimal weight gain. Now, secondary hypothyroidism will result in a low free T4 with a normal TSH. But one of the things you need to be aware of is that this is really rare unless there are other pituitary problems or a history of a brain tumor or brain radiation. So my advice is not to worry about borderline low free T4 with normal TSH. But, if the free T4 is significantly low, as in less than 0.7, and the normal range is usually about 1 to 1.6, then you can this would be a perfect time to send a consult to your MAVEN project endocrinologist, or to have the patient seen by your local pediatric endocrinologist. So moving on to a different scenario, you are now seeing a 15-year-old girl who complains of losing 10 pounds in the past 2 months without trying, even though she is eating more than usual. She also feels warm when other people in the same room do not, and her past medical history is unremarkable. So my question is, and you can type in, 1 or 2 words for case 3. What would you be looking for on the physical exam that might, help you in your search for a diagnosis? Okay, so tachycardia, I've seen, goiter, exophthalmos, thyroid enlargement. So the big winners here are goiter, which is seen in about 90% of cases, and tachycardia, which is also very common. Exophthalmos is a useful sign when it's there, but it's only seen in about half the cases of hyperthyroidism. So, so this is what you found: large symmetric goiter, tachycardia with a blood pressure that shows a widened pulse pressure, brisk pulses with an increased precordial impulse, warm, moist skin, and the patient has trouble sitting still. So my next question is, what tests would you order? And you don't have to order everything that might be relevant, but the things that you need to confirm your suspicion that this is a thyroid problem. All right. So we have free T4, free T3, free T4, TSH, and thyroid antibodies. Okay. And somebody suggested a thyroid ultrasound. So the answer is that the most important, if you want to say, I need to make a diagnosis right away so I can get this patient seen by an endocrinologist, then all you really need to do is a free T4 and a TSH. But because in cases that really have hyperthyroidism, they're not going to be borderline. The free T4, which normally can go up to 1.6 or 1.7, is almost always going to be greater than 3, and the TSH will be below the assay limit. Now, there's nothing wrong with ordering a T3, except that it doesn't, there are rare situations where the free T4 is normal and the T3 is high. But, these other tests, including various thyroid antibodies, imaging, or a thyroid scan, they can be left to the discretion of the endocrinologist. Your job is to confirm the diagnosis, and then this is one of those situations where you don't just say to the patient, why don't you call, such and so, so-and-so clinic and see when you can get an appointment. Because what you really need to do is talk to somebody at your nearest, pediatric endocrine center where you refer, because if you've got a case of, moderate to severe hyperthyroidism, they will generally, and they hear about it from you, they will generally get the patient seen within a week. Okay, now we're going to go on to, so when do you really need to order thyroid testing? Because one of the things that I found over the years is that thyroid testing is often not targeted to those situations where it's going to be helpful. So for screening purposes, either a total or a free T4 and a TSH is sufficient. Any patient who has a goiter, especially if it's something that was noted, recently in the last months or the last year. Obviously, if you have abnormal newborn screening test results, you need to follow that up. If there has been a significant fall off of growth in the past year, that can be a sign of moderate to severe hypothyroidism. And then the signs and symptoms consistent with hyperthyroidism, like we discussed. The most common symptoms of hypothyroidism, and I have to say many cases are asymptomatic, are new onset fatigue and cold intolerance. But thyroid tests are low yield, as I mentioned earlier, for obesity, most changes in behavior, a family history of thyroid disease, and irregular periods. So those are situations where people frequently order thyroid tests, but they tend not to be helpful. So, getting back to the obesity issue, hypothyroidism and other endocrine disorders like Cushing's disease are rare causes of obesity. And weight gain in severe hypothyroidism is modest, in the 5 to 10, 15 pound range. And it's not due to excess fat, but due to fluid retention. These patients often have a bloated facial appearance. So if rapid weight gain is accompanied by a slowing of linear growth, and that's assuming that the patient is not late pubertal where their growth, is leveling off, the chances of an endocrine issue are much higher. But the crux of the problem is we're often seeing patients who present with very nonspecific complaints such as fatigue or obesity that do not point to a specific medical explanation. So in hopes of finding an explanation, people often order a large number of tests just to make sure we aren't missing anything. In addition, metabolic panels and CBCs are sometimes ordered for screening purposes without any complaint. Now, I'm not saying that if you have severe fatigue, you shouldn't rule out anemia or, a chronic disease. But the problem is that when one of these tests is mildly abnormal, then should we assume that the abnormal test is clinically significant and or the cause of the child's complaint? So the problem is that the boundary between what's normal and abnormal is much fuzzier than many clinicians realize. And the definition of a normal test in most clinical labs is the 95% confidence interval. But what does that actually mean? So here's a test, and the results usually, will be a bell-shaped curve. And the laboratory normals will be between, will encompass 95%, including, the high and the low end of normal. So it's this area here, this little tail here and here, that can still be seen in a normal child, but may not be clinically significant. So how do we know if a person whose test is outside the limits has a normal variant result or has real disease? And the other problem with tests is that some tests have a fairly tight normal range. So a small deviation may be clinically relevant. For example, a normal serum sodium ranges from 135 to 145. So if the sodium is 149, that could be meaningful, especially if you are evaluating a child with excessive drinking and urination and you're considering diabetes insipidus. But another example, and this was an actual consult I got with from a MAVEN provider, is that they had a 2-year-old with new onset seizures, and they did a whole bunch of tests, which I thought was appropriate, but they were worried that a calcium of 8.8, which is just slightly below the normal range, might be what was triggering the seizures. And the problem is that, when you have seizures from hypocalcemia, that's pretty dramatic, and you're going to have a much lower calcium, usually 7 or below. So let's move on to another case, and I'm sure that this is a problem that you have occasionally encountered. So you have been referred, you have in your practice a 5-year-old overweight Hispanic boy who's sent to you for some screening labs. 3 days later, you receive a report that his CBC and urinalysis are fine, but on the metabolic profile, which was done at 10 in the morning, his glucose was 118. And the parents tell you that he always drinks a lot. So my question for you is, would you order a hemoglobin A1C, refer to pediatric endocrinology for a type 2 evaluation, or you could obviously do A and B, repeat the glucose, but make sure that the child is fasting, or order a 2-hour oral glucose tolerance test with insulin levels. So now this is case 4, and why don't you have 30 seconds to input your choice. Okay. All right. So we have two frequent answers here. Many people choose A, which is ordering a hemoglobin A1C, and many people chose C, which is repeat the glucose, but make sure the child is fasting. And obviously you want to talk to the parents, and you'll find out that he had eaten a pretty good breakfast. So the answer would be to repeat the glucose, but make sure the child is fasting. So here's something to consider. While type 2 diabetes is becoming more and more common in obese children who are greater than 12, basically the teenagers, it is very rare for type 2 diabetes to present as young as age 5. And that's why I wouldn't have ordered a hemoglobin A1C. A random blood glucose of 118, it could be very well be normal if the child had consumed a lot of carbs an hour or two earlier, and this boy had had a large bowl of cereal, turns out. And then since the renal threshold for glucose is about 180, you would not expect in this case, with a only a mildly elevated glucose, for polyuria and polydipsia to be present. And the important thing is that the parents did not report the new onset of polydipsia. So the parents, so this is obviously a case which probably does not have diabetes, but either type 1 or type 2, but a fasting blood glucose would be the best follow-up test. So the question then comes to, when should you order a hemoglobin A1C in obese kids to rule out diabetes or prediabetes? This is a tough question, and there really is no right answer. But yearly screening in severely overweight kids, and should that be a BMI of 30, a BMI of 35, in kids who are well in the teenage years, has been recommended, but it's rare that it will identify type 2 diabetes, which is we define as hemoglobin A1C 6.5 or higher. So it occasionally does, but not often. But much more often, the test will be in that borderline range, which is consistent with prediabetes. Now, we know that prediabetes may progress to type 2 over time, especially if weight gain continues, but studies show that we cannot predict how long that will take. It could take 6 months, a year, it could take 5 or 10 years. So as Jill mentioned earlier, I volunteer at an FQHC, and I am referred many such kids. And what the question really is, is there a good treatment, and when should you treat? And my cutoff has been, if the hemoglobin A1C is above 6%, and the child is very overweight and is, particularly if there's also a family history, I will treat with metformin, which, as you all know, is approved for first-line treatment for type 2 diabetes. It's not approved for prediabetes, but I can tell you that it, if taken regularly, it works in reducing A1C. And it's not going to put off diabetes indefinitely, but it can certainly delay. And the other question is, will identifying a child with prediabetes motivate the child and family to make the needed lifestyle changes, improve the diet, and get more exercise? And my answer to that is maybe. Sometimes it does, often it does not. So here is another glucose scenario. A 5-year-old boy had a screening urinalysis with 2+ glucose. He's a healthy child, and his random glucose on a basic metabolic profile is 225. The parents deny any history of polyuria or polydipsia. So the question is, how would you proceed? Would you advise the parents to remove high sugar drinks from the diet? Would you discuss this case with a pediatric endocrinologist? Would you do an oral glucose tolerance test with a hemoglobin A1C or have a blood glucose repeated if and when symptoms suggestive of diabetes develop? So I will give 30 seconds to allow you to enter your answers in the chat. All right. Well, I'm getting some good answers, and there's certainly nothing wrong with doing A, but if you had to pick one choice, I think B is the best choice. And the reason is that a random glucose of greater than 200 is diagnostic of diabetes, even in the absence of symptoms. 150 to 200 is suggestive, but greater than 200 means diabetes, unless the child has been, severely stressed or is on medications like high-dose steroids, which, as you know, can elevate blood sugars. And given the age of the child, this is going to be type 1 and not type 2. So during the time it would take you to schedule and review results of the oral glucose tolerance test, your patient could become pretty sick. So having a pediatric endocrinologist involved early on will make sure that definitive testing, which could include any of those things, a fasting glucose, an A1C, and if it's a borderline situation, an OGTT, they can be done and acted on promptly. So now I'm going to move away from blood tests and talk about a scenario which I think most of you have encountered, if not once, if not many times, at least once. So you are seeing a 7-year-old girl for your well child check, and you note that she has Tanner stage 2 pubic hair, and the parents mention that for the past 6 months she's had an underarm odor, and they are using deodorants. And you track her growth, and it's, she's tall and a little on the overweight side, but you are pretty sure on your exam, and you have to do this by palpation and not just inspection, that there's no breast development. Nothing else besides the pubic hair is normal, and the parents don't really seem very worried. So this is your choice for case number 6. You can order LHFSH and estradiol. You could do a different panel with testosterone, dehydroepiandrosterone sulfate and 17-hydroxyprogesterone. You could not order anything and reassure the parents without testing, or you could send them to pediatric endocrinologists and let them decide. And in this case, two answers are, you can give one or two answers. Yeah, I think only I only see 3 responses. Okay. So I see. All right. Okay. Well, this is good because what I'm seeing is that most of the people who responded would reassure the parents without testing. And that is what I would have done. But part of, the being able to reassure the parents without testing is that you've seen cases like this before, and you know that this is a benign situation. Now, I have to say that even among people in my field who see this a lot, first of all, LHFSH and estradiol are not indicated because those are, tests that you would order if there was breast development. The other tests are, looking at things in the androgen pathway, and some people order them, but most studies show that their yield is very, very low. And there's nothing wrong with sending to the pediatric endocrinology, and that's particularly the case if the parents are worried and you can't reassure them. In this particular case, the parents don't seem particularly worried. So, you could reassure the parents and not, spend any money on tests or referrals. So, but this is, in this case, you decide on option 2 and you order the tests. And these are the things that you find. And you find that the DHEAS, which is the major circulating adrenal androgen, is increased for age. The 17-hydroxyprogesterone, which is a screen for congenital adrenal hyperplasia, is normal, and the testosterone is normal. So the next move would be, if you've ordered these tests, what I would do is tell the parents that the tests are about what you expected, but if they wish, they could see a specialist just to be sure. You do not want to go ahead and start ordering your own imaging, because an adrenal tumor is an extraordinarily unlikely diagnosis, and the DHEAS is generally going to be above 500. And if the parents want to see an endocrinologist, it's certainly not urgent, because you're really not you mainly want to confirm that this is premature adrenarche. And this is one of the benign normal variants of puberty. Typically, the only abnormal finding is increased DHEAS. And, as I mentioned, LHFSH and estradiol are only helpful if breast tissue is present, and virilizing tumors are very rare. And if you saw an enlarged clitoris in a girl, that would certainly be worrisome. But in all my years of practice, I can think of maybe 3 or 4 times that that was a part of the presentation. So this is an example of something that many people send to endocrinologists, but once you've seen a couple of cases and have a comfort with it, there is no reason that you can't just reassure and monitor the family in your own practice. So now we'll get into something that's a little more controversial. And this concerns screening for vitamin D deficiency. So you are seeing an overweight 10-year-old boy, and you order 25 hydroxy vitamin D level. It comes back 20.5, with the lab normal range being 30 to 50. So on his CMP, his calcium and alkaline phosphatase and everything else are normal. So, we'll call these options 1, 2, and 3. Would you prescribe vitamin D at a high dose to get the vitamin D up to normal quickly? Would you assess his vitamin D intake and perhaps suggest a daily vitamin D supplement, or consider his vitamin D is fine and do nothing? So this is case 7 now. Okay. All right. So, we have a consensus here. We have consensus. Yeah. So this is a situation where, the guidelines for this situation are in flux. Because while the Endocrine Society in the past recommended that vitamin D levels should be greater than 30, most experts now feel that any level of greater than 20 is adequate, and that evidence of vitamin D deficiency, such as, low calcium, high alkaline phosphatase, rickets, is really rare unless levels are less than 12. So the truth of the matter is that measuring vitamin D should mainly be done when there is hypocalcemia, or you find a serum calcium of less than 8, especially in the group at greatest risk of vitamin D deficiency, which is breastfed, dark-skinned infants who are not getting a vitamin D supplement, or you see evidence of rickets on an X-ray or the exam. So for others, including obese children, I think it's best to assess milk intake and sun exposure. And, milk intake of 2 glasses or more a day usually is adequate, but there are a lot of kids that I see that drink no milk or just a little milk with cereal. And so a daily supplement of anywhere from 400 to 1,000 units of vitamin D is fine if vitamin D intake appears to be low. Now, in this situation, you could obviously do nothing because the vitamin D was above 20, but there's certainly no harm to advising a daily supplement. And this is far more effective than, repeat monitoring of vitamin D levels, because, that's useful when the vitamin D is really low, like particularly if it's less than 10. But for vitamin D levels that are that you shouldn't be getting in the first place, but are, borderline, really monitoring vitamin D is less cost effective than just supplementing with vitamin D. So let's talk about test ordering and the cost of healthcare. Ordering more tests than is necessary contributes to the rapid rise in healthcare costs without making children healthier. And this is particularly true when tests are ordered for completeness. And one abnormal result often leads to retesting. And one example of this is the mildly short child who is growing normal close to the 5th percentile. And there was a study published from Cincinnati that they looked at the diagnostic value of the typically ordered screening tests in over 300 short children where the history and physical were normal and that they were growing at a normal rate. And of those 300, only one patient, and this patient was not just a little, but very short, was found to have a lab test that was clearly related to his short stature. And that was a very high level of tissue transglutaminase IgA, which led to a diagnosis of celiac disease. But a few years ago, I gave a lecture where I included the cost of the workup. Now, these costs are from Children's Hospital, and Children's Hospital obviously charges more than commercial labs do. And also, insurance companies obviously are not going to pay for the entire cost, but you can see, if you had a patient that was self-pay, and this could really get fair, these are the typical tests that people order, and they can get really expensive. One thing I want to point out is, if you are monitoring treatment with thyroid hormone, a free T4 is essential. But, if you're just doing screening and need to order thyroid tests, a total free T4 will save more than $100 compared to a free T4. So here is some final thoughts that I have. And that one reason that we have so many abnormal test results is that often so many tests are ordered for patients with weight issues, mild short stature, with normal growth rates, and fatigue. And remember that 5% of healthy kids will have values outside that lab's normal test range. So if you're ordering 20 or more tests, there's a really good chance that at least one test result will be normal. So, I think the solution to this, and this is really important because of, how much we spend on healthcare in our country that does not contribute to better health, is to hold off on non-selective test ordering for non-specific symptoms while continuing monitoring the patient. And, I realize this can be challenging because parents often demand that you do something. So the most common type of question I get as a MAVEN volunteer is, I saw this patient with X and ordered, and then there's a long list of test results. And what other tests should I order? So my advice to you is to consider asking us what tests might be helpful for a specific scenario before you start ordering. And just a few days ago, I got a request of a patient who I thought, most likely had constitutional growth delay, and she hadn't ordered any tests or bone ages. And I said, that's perfect. Just follow the child's growth. So when confronted with an abnormal test that you did order, consider whether the result is likely to be abnormal in a clinically significant way before referring the child to the specialist. Test results that are slightly outside the reference range rarely cause problems. And, the question is, how important is it to distinguish subclinical disease states from normal variations? But on the other hand, as you saw, we occasionally have test results that are clinically significant, and the TSH of greater than 20 or less than 0.01 deserve immediate care. But as a reminder, if you're not sure, it's very easy to get a MAVEN volunteer to help with your with your patient. And I know that I try to answer my consults within a few hours. So I am going to end this talk, but I believe we have about 15 minutes for questions.
Dr. Kaplowitz, thank you so much, and really appreciated you doing the case-based learning and also the participation of so many of the listeners today. You could actually stop sharing your slide deck for the moment. And then if anyone has any questions, please feel free to put them in the webinar chat or through the Q&A icon on your Zoom toolbar. Or you could also use the raise hand feature and I can unmute you. So I'll just give you a few seconds for that. And also, maybe I'll go ahead and show you the MAVEN project portal just to remind you about submitting consults and where you would find Dr. Kaplowitz and some of our other MAVEN volunteers.
Yeah, I just want to mention that I am happy to accept questions about any topic that is directly or possibly endocrine, even if it was not on a topic that I covered in my talk.
Great. So Dr. Kaplowitz, here's a question. Any recommendation for the young child with a BMI over 45?
Wow, that's a toughie. How young is the child? And has rapid growth been occurring since infancy, or did it start at like when he started school?
Great. And I'll have either they can write back in the Q&A part or raise your hand just for that more information. But right now it just says for a young child.
Okay.
For a 3-year-old, 3 to 6 years old, for example, and with obese parents.
Yeah. That's a tough one because, there is no endocrine condition that is likely to result in that rapid weight gain in a young child. Obviously, the child already has risk factors for obesity with overweight parents in the scenario you describe. And, I think number one step would be referring to a dietitian, because sometimes you don't get a really complete history in your brief visit. But, I can also mention that there are situations where there is, particularly when the weight gain begins, rapid weight gain begins in the first year of life, when there is actually a genetic defect. There are a whole bunch of, genes, particularly, one MCR4 gene can cause early onset obesity, and there are even treatments. That does not mean that every child, needs a genetic workup, but just the thought that you will occasionally find genetics. But checking thyroid and adrenal and, other, insulin levels, of course, will be high. But, there's not a whole lot of workup that is needed in those situations.
Thank you. Another question is there a circadian rhythm to thyroid hormone release? And if so, is there a better time to obtain labs? If a teenage patient presents with hair loss or hair thinning, would you order TFTs?
Yeah, there is a circadian rhythm. I think the TSH levels are higher at night, but it's not a big difference in the clinical practice. The circadian rhythm, if you have abnormal tests, they're going to be abnormal all day. So you shouldn't worry about that. But the other question was, oh, the hair loss. Yeah, that's I was in charge of an initiative called Choosing Wisely. And the idea is to, identify situations where, testing may not be needed. And the dermatologists, included an item on hair loss and vitiligo. And there definitely is an association, patients with hair loss, it can be autoimmune, and hypothyroidism can be autoimmune. But generally speaking, if the patient does not have a goiter or any symptoms, thyroid tests are very low yield in patients with hair loss. And I cannot think of a single situation I've seen where severe hair loss ended up being, caused by significant hypothyroidism. So I would advise against testing unless you see something other than the hair loss.
Thank you. The next question, when would you consider medication management with obese children, given lifestyle recommendations have failed? And where do you begin? Metformin, Topamax, phentermine?
Yeah, excellent question. This comes up all the time. And I guess it depends on, I'm assuming that you're probably talking about a child who's over 10. And, I think that, obviously, we all hear nowadays about these wonderful GLP-1 agonists that can produce 15 to 20% weight loss. But I think you're also aware that most insurance and Medicaid plans do not cover these drugs for simple obesity unless it's progressed to type 2 diabetes. So my own choice is metformin, because, metformin has a very long and established a safety record. And, the underlying pathology in obesity as it progresses to type 2 diabetes is insulin resistance. Obesity is a state of insulin resistance. And if your obese patient has dark skin around the neck, acanthosis nigricans, that proves they have insulin resistance. So metformin, I would say that metformin can bring the hemoglobin A1C, if it's slightly elevated, down from 6.2 to 5.7, and it can lighten the acanthosis nigricans. But if you don't have type 2, if you don't have an elevated A1C, then it's a tough call, because lifestyle changes are not, always successful, but I think they should be, tried first. And then if the A1C starts to creep up to over 6, then adding metformin may help. The other obesity medications, unfortunately, like phentermine and topiramate, have more side effects. But metformin does have side effects in 20%, but they're GI side effects, but they're usually transient. So I occasionally will use metformin in somebody with a normal A1C, but I prefer the lifestyle first.
Great, thank you. Um, I will see if there's any more questions that come in. And in the meantime, I'm just going to remind people about our MAVEN project community portal. If for some reason you don't have an account, you can please reach out to MAVEN and we can make sure that you get an account. If you are a physician, nurse practitioner, physician's assistant, and if you go over on the left-hand column, you'll see it says specialties, and you can scroll down and see our 70 plus specialties. And if you go down to endocrinology, we have adult endocrinology and we also have pediatric endocrinology. So if you click on pediatric endocrinology, you can see that we have 5 physicians, and here's Dr. Kaplowitz. You can submit questions directly to Dr. Kaplowitz, or if you don't know who you want to select, you can just click first available and your consult will go into a round robin amongst these 5 volunteers when they're in office, and they're happy to help you if it's just a small question or if you have a more of a complex case, and they'll get back to you within 48 hours and oftentimes in less than 18 hours. So I just wanted to make sure to show you that. Yes,
Yeah,
Paul?
yeah, we had 2 more questions. One is the dose of metformin that you would start with. I usually start on 500 milligrams twice a day, and I often counsel patients to use a half dose for the first couple of weeks to minimize the side effects. But there was one question that we missed, which I think was important, was what monitoring do you recommend for a patient when the TSH is elevated but less than 10 and the T4 is normal? And that's really an excellent question, because obviously, occasionally these patients do progress to overt hypothyroidism, but it tends not to happen, immediately. So you're repeating the tests in 1 or 2 months is not going to help you. I usually recommend repeating the free T4 and TSH in 6 to 12 months, because, if hypothyroidism is developing, it will usually, happen over a longer frame of time. And you might also consider, particularly if the patient has a goiter and they're at higher risk of progressing, you might consider ordering a thyroid peroxidase antibody when you repeat the test, because if the antibody is negative, then, you might not, and the TSH is stable, then you might not worry about it. Whereas if the antibody is strongly positive and the TSH is creeping up, you want to keep an eye on it. I think that's it.
Great. Oh, there's actually one more that came in the Q&A icon. And it says, would you still recommend routine TSH for significantly elevated BMI based on what you mentioned about it being low yield? It's so
Yes,
common practice. So wondering, appreciate the vitamin D advice as well.
yes. We do not recommend TSH screening in obesity. One of the problems, is that it's been shown that obesity itself is a cause of not severely, but mildly elevated TSH. The whole bell-shaped curve is shifted over to the right in obesity. So obesity in itself, it's not the TSH causing obesity, it's the obesity causing the slight rise in TSH. So if there's one thing that you could, I hope, take away from this, is that screening for thyroid in obesity is not considered a good standard of care practice. And, unless you see something else that makes you worry, but you will not be missing any significant hypothyroidism by eliminating TSH from your evaluation.
Great, thank you. So I don't see any more questions right now. And if people end up having questions that come to your mind, you can always submit a consult on our Maven Project community portal. A huge thank you to Dr. Kaplowitz for giving this great presentation today. And thank you all for your participation in giving your answers in the chat, as well as all the great questions that have come in. A big shout out to all of Maven Project Clinic partners. You guys are amazing. Your patients are so lucky to have you, and thank you for all the hard work that you do. And Maven Project's here to support you. I hope everybody has a great rest of their week. Take care.